Assalamu alaikum. Today we will discuss the subject of a rather common problem in the surgical practice, which is the vermiform appendix. The vermiform appendix is considered by most of the surgeons to be a vestigial organ. Its important in surgery lies behind its propensity for inflammation and the subsequent formation of a clinical syndrome known as acute appendicitis. Acute appendicitis is the most common cause of acute abdomen in young adults. Appendicitis is so common that appendicectomy is the most commonly performed surgery in the abdominal operations. In spite of the advances in modern radiographic and improved diagnostic accuracy of the abdominal conditions, the diagnosis of acute appendicitis remains essentially clinical, and it needs a good mixture of observation, clinical and surgical science. Anatomy of the appendix. The appendix is present only in humans and certain arthropods. It is a blind muscular tube with a mucosal, submucosal, muscular and serosal layers. At birth, the appendix is very short and it has a wide diameter junction between its wall and the cecum. But with growth of the baby and the differential growth of the cecum produced its typical tubular structure by about the age of 2 years. For that reason, acute appendicitis is very rare in children below 2 years. During childhood, the continuous growth of the cecum commonly rotate the appendix into a retrocecal but still in an intraperitoneal position. In approximately 1/4 of cases, rotation of the appendix does not occur, resulting in the appendix lying in the pelvic position, subcecal or paracecal position. Occasionally, the tip of the appendix becomes extraperitoneal, lying behind the cecum or ascending colon. Sometimes the appendix does not migrate during development to its normal position in the right lower quadrant of the abdomen. In these circumstances, the appendix can be found near the gallbladder, or what we call it a subhepatic appendix. This produces some clinical difficulty in diagnosing cases of an inflamed appendix in this position. The position of the base of the appendix is relatively constant, being found at the confluence of the 3 tenucoli of the right colon, and it is just below the ileocecal valve. The mesentery of the appendix, which contain the appendicular artery, arises from the lower surface of the mesentery of the terminal ileum, and it itself subjected to a greater variation. The appendicular artery, which is a branch from the lower division of the ileocecal artery, passes behind the terminal ileum to enter the mesoappendix a short distance from the base of the appendix. The appendicular artery has a special character that it is an end artery. So once it is thrombosed or obstructed, the appendix will undergo ischemia and subsequent necrosis. The appendix varies considerably in length and circumference. The average length of normal appendix is about 7.5 to 10 centimeters. The lumen is irregular, being encroached upon by multiple longitudinal folds of a mucous membrane, and the lining epithelium is just like that of the colon, a columnar cell types of intestinal mucosa. The lumen of the appendix can admit a match stick. Acute appendicitis. The recognition of acute appendicitis as a clinical entity is attributed to Reginald Vitz, who present a paper in the first meeting of Association of American Physicians in 1886, entailed the perforating inflammation of the vermiform appendix. Soon after, Charles McBurney described the clinical manifestation as well as the position or the point of maximum tenderness in acute appendicitis, for which this site is named after his name, Charles McBurney. So it is named as a McBurney point, refers to the site of the maximum tenderness in the right iliac fossa in cases of acute appendicitis. The risk or individual lifetime risk of appendicectomy is 8.6 and 6.7% among male and female. This is a lifetime incidence of acute appendicitis and subsequent appendicectomy. Acute appendicitis is relatively rare in infants, as we describe the cause of this, and become increasingly common in childhood and early adult life. In the early adult life, the female has some predominance over male of acute appendicitis, but after the adult life, male has a slight predominance over female, but with increasing age, male's predominance has decreased regarding the incidence of acute appendicitis. Etiology. However, there is no known cause of acute appendicitis, but there are several situations blamed for its causation of the subsequent inflammation of the appendix and formation of the clinical syndrome of acute appendicitis. The suggested causes are a decrease in the dietary fiber intake and an increased consumption of the refined carbohydrate and which is mostly found in fast foods. Appendicitis is clearly associated with bacterial proliferation within the appendix, but still no single organism is blamed for this inflammation. Rather, a mixture of bacteria, including aerobic and anaerobic organism, is the usual mixture of bacterial proliferation in cases of acute appendicitis. Initiating event causing bacterial proliferation is controversial. However, obstruction of the appendiceal lumen is the main and the most important cause for initiation of inflammation. So there's some form of luminal obstruction, either by the commonest obstructing agent is called fecalith, or a stricture. As you know, fecalith is a stone-like material formed from undigested food and inspissated fecal material. The second common cause of obstruction is stricture within the appendix. As we said, the appendix has a very narrow lumen, so any inflammation of the appendiceal mucosa might be followed by a stricture with the subsequent obstruction. A fecalith, sometimes referred to as appendiculolith, is composed of inspissated fecal material, calcium phosphate, bacteria, and epithelial debris. Rarely, the obstructing agent may be a foreign body which is incorporated into the mass of fecalith. A fibrotic stricture of the appendix is usually indicate a previous appendicitis that resolved without surgical intervention. So the appendicitis, usually non-obstructive appendicitis, initially present with a recurrent attack of appendicitis which is resolved without operation. Finally, it will cause sufficient obstruction of the lumen with irreversible progress to inflammation and the formation of the full clinical picture of acute appendicitis. Obstruction of the appendiceal orifice by a tumor, particularly carcinoma of the cecum, might be one of the obstructive lesions, especially in elderly. Intestinal parasites like Oxyurus vermicularis or pinworms and the Ascaris lumbricoid might cause obstruction of the appendiceal lumen. Obstruction of the appendiceal lumen seems to be an essential for development of appendiceal gangrene and perforation. So most of the gangrenous and perforated appendicitis usually ranked as an obstructive appendicitis rather than non-obstructive one. So we have two types of acute appendicitis, obstructive and non-obstructive one. And later we will discuss these two entities. Many cases of early appendicitis, the appendix lumen is patent despite the presence of mucosal inflammation and lymphoid hyperplasia. Cases among children and young adults suggest an infective agent, especially viral in origin, which initiate the inflammatory response. For recurrent inflammatory response of viral origin responsible for the formation of the subsequent stricture and obstruction, usually culminating in a full picture of obstructive appendicitis. Lymphoid hyperplasia narrows the lumen of the appendix, leading to luminal obstruction and subsequent appendicitis. Once obstruction occurs, continuous mucus secretion and inflammatory exudate increase the intraluminal pressure, obstructing the lymphatics. Further edema and the mucosal ulceration develop with bacterial translocation. The bacteria will translocate from the lumen of the appendix, which is usually a normal flora of colonic type. It will translocate through the submucosa and through the wall of the appendix to the surrounding peritoneum. At this stage, before the further inflammation occurs, resolution may occur at this point, especially in non-obstructive type of appendicitis. And this resolution either occurs spontaneously or in response to treatment, usually with antibiotic therapy. If the condition progresses, further distension, if the condition progresses without resolution, further distension and the appendix may cause which may cause venous congestion, ischemia of the appendix wall with ischemia, bacterial invasion occur through the muscularis propria submucosa, producing acute appendicitis, which is acute appendicitis, you should know, one of the forms of localized peritonitis. If left untreated and perforation occur, the localized peritonitis may become diffuse peritonitis. The fear of acute appendicitis is the widespread peritonitis if perforation occur. And as you know, diffuse peritonitis carry a very high mortality rate. Finally, ischemic necrosis of the appendix if unrelieved obstruction or surgical intervention has not been done. The appendix wall become gangrenous, and the bacterial contamination of the peritoneal cavity, alternatively resulting in a localized then diffuse peritonitis. The alternative way is that if the greater omentum is well functioning, the greater omentum will move together with a loops of the small bowel toward the inflamed appendix, walling off this inflamed appendix and preventing spread of peritoneal contamination, resulting in formation, what we call it in a clinical entity, of appendicular mass, which is a phlegmonous mass or paracecal mass, which may be converted to an abscess. Rarely, appendiceal inflammation resolves, leaving a distended mucus-filled organ termed mucocele of the appendix. It is the potential, as I said, it is the potential for diffuse peritonitis that is the great threat of acute appendicitis. So the greater threat of acute appendicitis is the potential for formation of diffuse peritonitis that is which carry very high mortality. Peritonitis occur as a result of free migration of bacteria through the ischemic appendicular wall, or frank perforation of the gangrenous or perforated appendicitis, or perforation of already existing appendix abscess. Factors that promote this process include extreme of age. The extreme of age favor the diffuse peritonitis rather than localization because of the omental deficiency. In children and young children, the omentum is not well developed and cannot reach to the lower abdomen to seal off the inflamed appendix. In addition, the elderly, they have an atrophied greater omentum. Again, it cannot move enough to the pelvis or the right iliac fossa to seal an acutely inflamed appendix. Other cause is immunosuppression. An immunosuppressed patient is more liable for perforation, gangrene, and diffuse peritonitis. Patient with diabetes and patient with obstructive type of appendicitis, which is commonly caused by fecalith. The cause of potential for diffuse peritonitis in cases of perforation, when the appendix is obstructed, the obstructed appendix is made under high pressure. So once perforation occurs, massive spread of the intraluminal content and bacteria occur through the whole abdomen, and diffuse peritonitis can ensue. In addition, a free-lying pelvic appendix, which is away from the omental defense mechanism, or previous abdominal surgery, which limits the ability of the greater omentum to wall off spread of peritoneal contamination. So all these factors favors diffuse peritonitis rather than localized peritonitis if acute appendicitis develops. Clinical diagnosis of acute appendicitis. We will start with the history. The classical features of acute appendicitis begin with poorly localized colicky, abdominal pain, usually in the periumbilical area. This pain is usually of visceral character. Visceral mean colicky, poorly localized, conveyed by the autonomic nerves that supply the visceral peritoneum. This results from distension of the appendix, and the distension of the appendix causes stretching of the overlying visceral peritoneum and will convey the pain of autonomic characters. Which is colicky, periumbilical, and poorly localized pain. The central abdominal pain is associated what we call it protective pylorospasm, which is manifested by anorexia, nausea, and usually two attacks of vomiting. Anorexia is a very useful sign, and it is a constant feature, particularly in children. And has been mentioned that a child with a normal appetite probably has no acute appendicitis. The patient often gives history of similar but milder attacks, which mean that the patient is suffered from a subclinical acute appendicitis, but yet obstruction has not occurred until this point of sufficient obstruction occur and the clinical entity of acute appendicitis become apparent. A family history for appendicitis usually occur in third of cases. So acute appendicitis may be familial. It sometimes run in families. With the progressive inflammation of the appendix, the next common symptoms the patient can describe is the pain, which has been periumbilical, colicky, and poorly localized. It becomes shifted to the right iliac fossa. This shift is usually due to irritation of the parietal peritoneum. This is called visceral somatic sequence. Visceral somatic sequence. The parietal peritoneum is supplied by somatic nerves, and the character of pain will change from poorly localized to well localized, sharp, stabbing pain in the site of inflamed appendix, which is the right iliac fossa. So the patient often report as this an abdominal pain that is shifted and change its character. Typically, the pain is exacerbated by coughing or movements. The classical visceral somatic sequence we have described of pain is usually present in only half of that patient. So 50% of patients describe or present with the classical visceral somatic sequence. And we repeat the visceral somatic sequence as the patient described as periumbilical, central, colicky abdominal pain, which after a few hours shifted to the right iliac fossa and changed its character from the colicky to a sharp, well-localized pain. This feature of visceral somatic sequence is usually present in only half of patients. The other half of patients present either with a predominantly somatic or predominant visceral presentation. There might be an increase in the temperature and tachycardia in the later stages of acute appendicitis. Earlier, the temperature may be normal or sometimes subnormal with mild increase in the pulse rate. However, extreme or high temperature in children may exclude the possibility of acute appendicitis, and it may denote the other causes which might mimic the acute appendicitis, example, mesenteric lymphadenitis. Typically, two clinical syndromes of acute appendicitis can be disconcerted. Acute catarrhal, a non-obstructive appendicitis, and acute obstructive appendicitis. The latter characterized by more acute course with rapid progression of symptoms, and the pain may be generalized from the start. Vomiting may be more copious in those patients. So the visceral somatic sequence of acute appendicitis may be more rapid and more severe in patients with obstructive appendicitis than with patients of non-obstructive one. Risk factors of perforation of the appendix in patients with acute appendicitis: extreme of age, immunosuppression, patient with diabetes mellitus, fecal obstruction or any cause of obstruction, pelvic appendix and previous abdominal surgery. Clinical signs in appendicitis, as we said, there might be pyrexia, especially in later cases of acute appendicitis, localized tenderness in the right iliac fossa, especially in the McBurney point, muscle gardening and rigidity together with rebound tenderness. Signs to be elicited in those patients' special position or special situation of patient with acute appendicitis is the pointing sign. We ask the patient to point at the maximum site of tenderness. If he point at the McBurney point, so this is more probable case of acute appendicitis. The second sign is Rovsing sign, which mean by palpation of the left iliac fossa, deep palpation of the left iliac fossa results in a pain or feeling of a pain in the right iliac fossa. Psoas sign occur in cases of retrocecal appendicitis in which the inflamed appendix is in contact with the psoas muscle, causing flexion of the hip joint, and when we try to hyperextend the hip joint, the patient feel pain in the right iliac fossa. This is called psoas sign. The other sign is the obturator sign, which occur when the appendix in a pelvic position in contact with the obturator internus muscle, causing internal rotation of the hip joint, and an attempt to external rotate the hip joint where the patient will feel a pain or pain deep in the pelvis when the appendix become irritated by the contracted obturator internus muscle. Thank you very much.